Okay.
Good morning or good afternoon, everyone, wherever you are in the world. To begin with, I would like to thank you all for the invitation today. It's a great pleasure to be here with you today to celebrate together the 25th anniversary of the Sports Medicine Association of Serbia. It's a great privilege for me to be here, but at the same time, I feel very emotional because I do remember that that moment when a young group of people from Serbia started the initiative of creating this association. Thank you to my very good friend, Professor Nenad, for this invitation. We started together, young doctors and scientists 25 years ago, and I'm very proud of where the association is at the moment. So I wish the Sports Medicine Association of Serbia bigger success on your way, happy and successful moments to come for many, many years. Now, let me introduce myself. My name is Dora. I am coming from the UK. I'm the Secretary General of the European Federation of Sports and Exercise Medicine, the Secretary of the Development Commission of the International Federation of Sports and Exercise Medicine, and one of the executive board directors of the British Association of Sports and Exercise Medicine. I am a consultant in sports and exercise medicine and an orthopedic surgeon. Now, it was a very difficult decision about when I thought about the topic of this lecture. It was a difficult decision to make, but finally I decided that the topic will be related to the exercise prescription for health, a topic for which we have worked for many, many years with the Serbian associations in the European Federation and in the European countries. So I hope you will enjoy this lecture today. I'm going to talk about the way we treat with exercise using the multidisciplinary, or if you want, the interdisciplinary model in sports and exercise medicine, and how it works in practice, because a lot of people talk about this model, but they haven't used it in practice. So this is what I'm going to share today with you. And also I'm going to talk a bit about another big topic, this biopsychosocial model, and how we implement this and how we use this in our everyday practice in the UK. Now, I'm privileged to work in biggest state-of-the-art defense rehabilitation sports medicine center in the UK. And then a lot of people, they will say, yeah, okay, you have the opportunity to do so because you work in such place. I always say, and that it's not the building making the perfection, it's not the building, but it's the people making the difference of our patients and in the treatments. Now, coming from the UK, UK is a country working a lot on physical activity lately, the last few years. And we work a lot with exercise prescription for health and for different medical issues and problems. We do work a lot, and we have particular physical activity guidelines. And here you can see in my slides, this is a page from the newsletter of BASM. It's a magazine we produce every 4 months. We have here the new Chief Medical Officer's Physical Activity Guidelines came out a few months ago, and you can see the different guidelines about physical activity for adults, older adults, children, patients or athletes or people with impairment, ladies in pregnancy, and so on. All this is available online and for free. So please have a look and share if you want. We agree with the new guidelines for physical activity from the World Health Organization. They still work on them and will come out very soon. We also have something, we call it moving medicine. This is a fantastic initiative from the Faculty of Sports and Exercise Medicine on how to inspire and how to prescribe the doctors to prescribe movement or prescribe exercise for health. Again, you can find in the Moving Medicine page all the sources for free on how to prescribe physical activity for different musculoskeletal issues, for different problems, whether this is cancer patients or mental health issues and so on. Now, despite all this, despite all the hard work we do in the UK, all the organizations, the picture in the right is the picture we see still every day in our hospitals, organizations, or clinics. People are very happy and keen to go to pick up their prescription or be maybe referred for a surgery, but it's very difficult yet to change their lifestyle. Why we're doing this? We're wondering every single day, and we try to find a solution. And the next question is, the elephant in the room. Is it us? This is a very fresh article came up, I think it's end of 2019, just a few months ago, in the Journal of Physical Therapy and Orthopedics. The question is, do we have a part of responsibility? Do we have responsibility for all this? Do we medicalizing the normality? And how this can happen? Well, I see very often patients in my clinic, as many of you do. We talk about imaging. Some of the examples what means medicalizing the normality. So we talk a lot about the pictures we see. I see here patients, and I will see in young, very active individuals what we call femoroacetabular impingement. Talking through this to our patients, you alarm them. Femoroacetabular impingement is something we see very often to those very active individuals, but it's not something our patients should worry. It's not something our patients should be sent for surgery, for example. Do we send very often for surgical interventions when it's not necessary to do so? Again, we see this every single day. For example, say for a condition like rotator cuff issues, we noticed that we sent patients so very often for a surgery when when rehabilitation and exercise would help more if you follow them for at least 3 months. So we maybe have part of the responsibility. Now, I know it's very difficult, it's very easy for me to say, but we do it, we try hard and we do it, and we achieve our good results working as a team. And without my team, I would be no one, to be honest. And obviously you didn't expect me to come 100 years later to say what Henry Ford said more than 100 years ago. Coming together is a beginning, stay together is a progress, and working together is success. I bet you know this. But I will say, I will stay here in what this picture says. A successful team is a group of many hands and in one mind. Remember this, it's very important to work together, but we all be in the same boat. We all have the same opinion, and this is what we advise our patients, so our patients not confused. And something else which the older generation of doctors and clinicians and scientists still haven't achieved, maybe. It's a question I give to my colleagues and every single day. Is it time to stop chipping away at our own silos and start communicating with people more, rely more on our colleagues, talk more to them, listen to their opinions, ask for their opinions, communicate? You know, the old generation of the doctors, like I am, we used to see the patient in our cabinet, just us and the patient alone, and prescribe some medication or prescribe surgery, and that's it. We never, in the past, we never used to ask for a second opinion. We didn't ask for if one of our colleagues has a different, has another advice to give us, or share this case with other people. So I think that it's time to stop chipping away at our own silos and communicate with the team and feel that everyone in the team is equal. So how we achieve this? We have heard a lot about a multidisciplinary team and interdisciplinary team. What is this? How it works in practice? We do know that multidisciplinary team approach to the patient care is the best possible. We have the best outcomes achieved by professionals collaborating in work, learning, mapping out the prognosis, the diagnosis, generating new ideas, and implementing these ideas to the treatment of our patient. Then what is it? Yeah, obviously it is a team of professionals, including representative of different specialties and disciplines. We coordinate the contribution of each profession with little overlap there. So all these professionals working in parallel, and they have clear roles. Each professional sets their own individual goals with the patients, communicate these goals and the outcome with the rest of the team, and where this is appropriate, where with the interdisciplinary approach, it's a bit different. The multidisciplinary team and the interdisciplinary team is led by a consultant or a team leader. Then with the difference with the interdisciplinary team, which is my favorite, and approach to the patient, is that within the interdisciplinary teams, the participants or the people from all the specialties, they share the goal and then overlap the practice rather than working on a separate discipline-specific goals. So the goal is one, we set it together and we work on these goals all together. So what these teams involve, they're professionals involved in joint problem solving. We're working beyond our own scope and practice. The treatment goals are overlapped, and then we collaborate with all the other specialties. We have regular communication between us, and then the team is able to work more closely and achieve better outcomes. How we do this? So we, when we plan our clinics, we meet all our admissions, we meet all together, all the in this interdisciplinary team. we look at the patient's problem, and then we know the patient is going to come. Then after we've seen the patient, we see the patient all together. After we've seen the patient, then we have another meeting, planning meeting, how we're going to proceed from there, and how to set the plan, the treatment plan for this patient. So why I said this with you today, because in the military environment, when I do work, the multidisciplinary, interdisciplinary assessment, following or not by rehabilitation programs or admissions, it's a long tradition, and that's why I can share all our experience and our good outcomes together with you. So if we admit a patient, then the patient will receive an intensive, goal-based, individual, residential rehabilitation program. If we will see him only or her only in the clinic, he doesn't need to be admitted, then he will be seen by the team again, and we will set a program for him, and we will send him back to his base, where all this program will be followed for the next 3 months. And we will have a local physiotherapist or a local exercise instructor to oversee him or supervise him or her. If we admit the patient, on admission, all our patients undergoing a comprehensive clinical assessment again with each member of the multidisciplinary team. And then we create, a program individually tailored according to the patient's pathology, the patient's needs, and so on. So probably many of you will questioning how this is happening. You know, most of you are familiar with this typical setting of the clinic when the patient is going and see the doctor, and they have this conversation, and the doctor will give some advices and treatment, prescribe the treatment, and that's it. No, this is the MTD clinic setting. As you can see in this picture is taken just 2 months ago, before the lockdown, or 3 months ago, before the lockdown. So we have here, this is one of our everyday clinics. This is our everyday life. So we have here the patient who is ready to meet the team. The team know everything about the patient. All of us, we went through our patient notes, the images, the previous communication, the clinical diagnosis, if there is some. And we meet the patient. Here is the consultant or the clinical person, the doctor. We have an occupational therapist, because many of those patients are either athletes, so we need to look at their occupational needs, or the soldiers or coming from the military, so they have different, similar to athletic population needs, so the occupational therapist is very important. We have a senior physio and maybe a second physio there with us. We have an exercise instructor or a sports scientist. We have podiatrists and different other specialties according to the patient needs. And we know their needs because we have read a lot about him or her before the clinic. And then we have the extensive MTD meeting, which consists of the specialties you've seen before, but also we will have people, they need to use the service of our biomechanist in relation with podiatrists, and if they have such problems. Nutritionists, they will be seen by a pain consultant or a pain nurse a pain psychologist if need to. They will be seen by a mental health professional, and if they are close to the end of their athletic career or the military career, they will see a vocational occupational therapist. But it's not only this. Again, we work very close together, and you can see here myself and my very good colleague, consultant radiologist, performing this ultrasound to one of our patients, and we have, of course, the permission of our patient to take this picture. What I'm doing this, I could definitely do the ultrasound for this patient, but what instead I did, I am just presenting in this clinic, working close with my consultant radiologist, explaining the clinical picture of this patient, because you see the consultant radiologist she's not doing the clinical work, and therefore I'm here, as you see, with my notes and my letters to explain everything about this lady's clinical pathology, and then help him to look at the right side of the knee joint, let's say, of the hip joint, of the groin, or whatever we want to do. So the outcome of this is perfect. This collaboration gives us much better results to my experience. Now, I said before extensive team, and why extensive team, and why in sports and exercise medicine, when we deal with people are young, are very fit, are elite athletes, or they are very high performance military personnel, they need the extensive team. Well, I will let you know later on. This is our facilities, and yes, we had the royal visit just a week before the lockdown in our facilities. You can see here the computer assisted rehabilitation systems. We have our labs and different access for the facilities. Why then we need the extended musculoskeletal, multidisciplinary team? Why so many people should be involved in the treatment when we treat with exercise? Well, because one size fits all does not apply for exercise prescription. When I see patients and I admit them to work with them on, say, rehabilitation or exercise prescription programs for the hip joint, I may have 5 people with the same pathology, but I have 5 different personalities and 5 different identities, and so these people, they have different needs. One of them is one of my elite athletes who wants to go back and perform straight away. One of them is an elite athlete who says that now I want to finish my career, and I will be happy by having a good family life and be functional and be pain-free. Someone else who is a military personnel will say, well, I want to do my job and I want to pass my test. And the fourth one will say, I want to have a happy family life. I want to help my wife or my husband and have an active life with my children. And so on. So everyone is so individual, and we tailor-made all the programs according their needs. And then how we achieve this, and what are the other factors affect these treatments, how we can improve these treatments, looking at each of our patients as an individual. What are the other issues we should also reach or investigate? I think that this is the key to the success, although it's not an innovation, it's not something came out or is related to, say, artificial intelligence. This is 40 years old, and this is a theory from Đorđe Ćurčić back in 1977. Đorđe Ćurčić argued then that the psychological and social factors influence the biological functioning and play a huge role in health and illness. And I'm asking the question to you, as I asked the question to my colleagues a long time ago. Is it time to prioritize the biopsychosocial approach in sports and exercise medicine? Well, I do believe that patients' problems will not be solved by addressing a superficial pathology alone. And we see this in our clinics every single day. So please do not underestimate the importance of the biopsychosocial model in sports and exercise medicine. And this is why we need the extensive muscular and multidisciplinary team and people like the mental health specialists, the occupational therapists, the pain psychologist, the sleep specialist if you want, and many others. And I'll explain you exactly what I mean. So the biopsychosocial model is looking at the biological factors, at the psychological factors, and the social factors in everyone's life. So what it is, the biological factors is our genetic material, is the way we are, our structure and function, our physiology, our immune system response, our anatomical systems, how we are made. Do we have valgus needs? Do we have varus needs? Do we have any other issues? And obviously our injury. The psychological factors is our lifestyle, is our beliefs, is our personality. Do we believe that, you know, this problem will destroy my life? How is my emotion? Am I affected by mental health at the time? Am I able to make decisions? Am I able to, according to my mental health status, to motivate myself to exercise or to follow my exercise prescription for my health? And then it's the social factors. Do we have any support from our family to continue with this treatment? We have available resources to do this. Can we go to the local gym? Do we have a community to support us, or a community where providing these resources to us? What is our ethnicity? Is that something affecting our treatments? What are our relationships? I know that all looks complicated, but we need to look at all these things. A phrase I like to say and share with my patients when they're coming, just a bracket here, the patients that are coming to my clinic are patients they have been seen for 3 or 4 years or more or less from different specialists, different doctors. Maybe they had many scans, they had x-rays done, they had bloods taken, they had surgeries, and yet they haven't found a solution for the problem. They are elite athletes, they're suffering a lot because of the absence from their activities and their sports. their high performance military personnel, where their military life is more important than their personal life. And this is the example of the psychosocial model. What I say to these patients, they're coming with a lot of expectation to see me and my team, obviously. And they will come believing that, you know, we have the magic wand, or I will send them, we have the magic cure, or I will send them to a surgeon to have their surgery, and this will be great. And I always say to them, okay, imagine that, yeah, you need the surgery, but imagine that yourself is a big wall. This big wall is full of cracks, full of holes, and you ask me to bright this wall with to paint this wall with a bright color, and then as of a sudden all those cracks and holes will disappear, and you will think, and other people will think, that everything is covered. Well, it may be covered, but the problem will exist, and we do know this. And therefore, we first need to heal or treat all these cracks, to fill and heal all these holes, and then cover and paint the wall with a bright color, or proceed with the surgery. So imagine all these biological, psychological, and sociological problem in someone who has knee osteoarthritis or knee problem. Their body or the biological part is the swelling in the joint, it is the weakness in their hip or the weakness on the knee. And then the sociological issue is the world around them. I cannot sleep because my partner is snoring. My house is so big and I will not be able to continue with my problem. I have stairs in my house, and it's so difficult to climb these stairs. And also then is the psychological, is what I need the surgery. I'm so stressed about my injury. How I'm going to do these exercises this doctor says, or this doctor suggests, when this is going to wear and tear my knee more. So you can see that we have many issues here, many cracks to heal and treat before, and many holes to fill before we go to the next step, give the pill or do the surgery. And hence, where is the role of the multidisciplinary or the extended multidisciplinary team? And I know what you're going to say next, and I am one of those people where my life is chaotic. I'm extremely busy, and I have long lists to do and long waiting lists to perform and in my life. I'm sorry. So I have two pictures here. This is for the surgeons in the room. Huge amount of searchers. We don't know what to prioritize. We don't know what to use. And this is for the chocolate lovers in the room. So whether you're a chocolate lover or a surgeon, I bet that this is your waiting list and this is your to-do list. Mine is the same, but my patients' needs are above all needs, and I do work with my team to put things in order. We do dedicate a lot of time to our patients. And you know, if you dedicate this time, your outcomes will be much better. So how we do this? We said before that we are all very busy, and everything I'm asking from you today is very high demanding and enthusiastic, and you will think that, oh, I don't have time to do this. But there are some clever people out there prepare some work for this, and this paper came out in the American Journal this year, just a few months ago, with few little secrets, and this is a great slide, I think, some practices how to foster the physician presence and the connection with your patient in the clinical encounter. And how you do this, this will save you definitely time. What I told you before is I never see a patient for the very first time without knowing anything about him. The day before my clinic or 2 days before my particular clinic, I will dedicate time to familiarize myself with my patient, and I will know everything about them. So they will feel confident when they see me, because they know that I've read all the letters, I've seen all the x-rays, I know almost everything about them. And then, and this is what we say here, prepare yourself with intention. So familiarize yourself with the patient you're going to see or meet. Create this ritual to focus your attention before this visit. Try to be prepared for a meaningful interaction. And once you know all this, and you know very well your patient before you met him, then you meet your patient, and please listen intently and completely. It is very important. There is a lot of evidence out there from last year saying that the patient, they feel that they've been listened, they have good outcomes. Indeed, I had many patients, they sent personal messages this year, and I keep these messages because it's so important for me, but it's very important for my younger people of the team to understand this, saying thank you very much for believing on us, for believing to our story, for listening to us. So how you do this? Just be honest, first of all. Sit down, be relaxed, position to yourself to a posture like your body language, to listen to your patient. Try, it's very important, do not interrupt your patient. At the moment, your patient is the most important part of this clinic, and also your patient is the most valuable source of information. So when I talk to my patients, I say to them, yes, I have read everything about your history, but I want to hear from you because you are the most valuable source of information. From their body language, you can understand a lot. They can tell you more if they know that you dedicate time, you listen to them. Then agree on what matters the most. So find out what are your patients' priorities, what they want, what is their goals. I always ask them to say, to let me know what are their expectations from this visit. What are their goals? Do they want in the future to play with their children, or in the future they want to be Olympic athletes? It's very different. So then concentrate and try to achieve those goals. Then connect with your patient's story. So consider what other factors, what we said before, influence your patient's health. Remember, biopsychosocial model. Remember other factors. And also, do not forget to congratulate and celebrate their success, their offers, their efforts. So if they did something right or they tried hard, acknowledge this. Congratulate them for everything they've done. Even you, I say to my patients, thank you very much for being honest with me, or thank you very much for the fact that you worked so hard. And then explore their emotional cues. So try that day to be a trusted partner. Try to create this relationship where your patient trusts you. This is the beginning of a journey based in honest, trustworthy communication, and always have better outcomes. So your patient emotions is something you can learn from. And there are other papers out this year talking about the same issues. How to work, for example, this is something came out again in, I think it's BDSM 2020, just a few months ago. It's a roadmap to managing a person with musculoskeletal pain in this slides, in this infographic, but it's for every other medical condition. So what you do, obviously you have to screen about your patient, about the risk factors, and of course red flags and all the regular things you do in a clinic, but embrace with the patient, embrace with their own needs. Something else is very important is educate your patient. Educate your patient beyond the words, using different learning approaches and activities. For example, when a hip patient, let's say, coming to my clinic, I will ask him, what do you understand about your condition? If we say he has a labrum tear, I will ask him, what do you understand about intra-articular hip pain? What you understand about your own pain? What you understand about your labrum tear? What I do, me or my physiotherapist, we will draw down a scheme or a picture of a hip joint, and we'll explain to them where their pain is coming from, so that now they know more about their pain. We will also educate them how to deal with their injuries, and we will coach them towards the self-management. So we'll educate them, we'll give them the education for them in the long term, because these patients will come to us, we'll educate them, we'll send them back for 3 months to do the exercises, but we will not be with them. So how to manage in the long term, how to use these exercises, how to progress, and about progressions and regressions, because these patients, they will go back at home and some days they will have more pain. They need to know what to do in this case, and obviously address their comorbid health factors and all the other factors we discussed before related to the biopsychosocial model. And again, treating with exercises, this is the 6 actions to manage a person. Here is with musculoskeletal pain, irrespectively the body region, but again, it is for every patient and for every single condition. So screen for the psychosocial factors and health comorbidities, and talk to the team and try to solve all these problems. Embrace patient-centered communication. Your patient is the most important and the most valuable source of your information. Educate your patient beyond words using learning approaches, different learning approaches. Be creative, try to be creative. Patients love this. Try to inspire them, to motivate them. Coach them towards self-management, what to do when they are alone at home, and how to manage. Obviously, address their comorbidities, and then, of course, talk about their goals and what they can do to achieve their goals. I know that I gave you a lot of information today. This is something I do every single day, and I don't expect you to get all this information and remember all this information. And for this reason, I have summarized a few tips and tricks here to take home from me today. And how we'll work with a person-centered approach. So please create tailor-made programs, individual programs based to your patient's pathology, personality, and identity, nature and character. Inspire and empower your patients to engage with exercise. Being creative, try to empower them with different examples. Stop chipping away at your own silos and make better use of your team. Collaborate and communicate with your team. Create this perfect environment, team environment to work with. We know that the outcomes are great when this works. Appreciate and don't underestimate the biopsychosocial model. Appreciate the importance of this model 43 years later. Provide individual plan to help your patients manage their symptoms exacerbation, what we say the coaching, progressions and regressions. So when they are they're not with you or they are alone at home, how to proceed from there. Do not treat your patient's knee, hip, hand. Treat your whole patient and not the injury only itself. Be well prepared and know your patient before their arrival in the clinic. It is very important to know what this patient have heard from different specialists, why the patient will not trust you because he had so many people saying different things, for example, that he will come to you and you will know him. Then listen to your patient carefully without interruptions, okay? This is something I always say. I know that can be, your team can feel tired at the end of the day, but you know that you made a difference. So ask and listen to your patient's story. Listen carefully. Then ask about your patient's coping mechanisms. We can provide everything, but do they have the coping mechanisms to deal with at the moment? Do we need to help them with this? Discuss their expectations and goals, where they want to go from here. So do they have very high expectations for the injury? are they ready to accept or to decrease, let's say, their expectations? Are the expectations realistic? Can they achieve this? You don't want to not to know their expectations, and then after 3 months of treatment or long-term treatment, you haven't met their expectations because you didn't know what they wanted from scratch. Dedicate time to educate your patient, and you remember that you can't educate beyond words. You can use any example you want in order to give all the information, and in order to know that you get the whole information. The patient is educated, your patient left the clinic knowing more about his condition. And again, individualize the care, because everyone is different. And as we said, one size doesn't fit all in sports and exercise medicine. And this must include the psychosocial element. Work with your staff and make sure that there is consistency in the messages across the teams. A lot of patients are getting very confused. They don't understand the medical terminology we use. If we give them any different opinions, then it's when they're getting more confused. You never forget that we work as a big team who has one goal. You remember what I told you in the beginning, many minds, many hands, but one mind. So us is over me. There is no space for egos between the members of the multidisciplinary team. And with all this in mind, I hope that I managed to add a little bit in your future clinical practice. And I wish you a happy treatment. And once again, I would like to say thank you to the Sports Medicine Association of Serbia and its president, Professor Nenad, for this invitation. Happy anniversary, and wishes for success in the future, and hopefully we'll be again together in another 25 years to celebrate together the 50th anniversary of your Sports Medicine Association. Thank you very much for inviting me. Happy treatments.